The doctor told me that, look, you have hepatitis B, so you cannot go overseas. No one at all from my village had that opportunity to go overseas for study. And for sure, my parents would not be able to afford any of that. So having a scholarship to study overseas is actually a really big deal for someone from a village in the north of Vietnam. And I was lucky enough to secure a scholarship to study in Europe. And as a part of the paperwork, I have to go through a health check, and hepatitis B test is among the health check. So when I came to get the result, the doctor told me that, look, you have hepatitis B, so you cannot go overseas. And then I had to reject the scholarship just because he told me so. I don't know why, by that time I didn't challenge him or explore more, whether what he said was correct. But look, as a first year university student and you had no experience in life, and then you tend to trust everyone that deemed to be more superior than you, like the doctor in the hospital.
In the time it takes to watch this 30-second video, someone will lose their life to hepatitis. It could be your parent, your partner, your child. It could be you. But it doesn't have to be this way. There is a cure for hepatitis C, a vaccine and effective treatment for hepatitis B. We have the power to eliminate hepatitis and save 1.1 million lives each year. It's time to act. Hepatitis can't wait.
Hoy es un día muy esperado para todos los integrantes de la Asociación Buena Vida, porque celebramos la cura de varios pacientes de hepatitis C. Nosotros en nuestro grupo decimos que vivir con el virus de hepatitis C es sentir que uno tiene una bomba de tiempo dentro de uno y que no sabe cuándo va a explotar. La cura significa desactivar esa bomba. Por eso estamos todos juntos hoy para festejarlo, entregar las remeras con la inscripción de hepatitis C curado, y ese es el momento cúlmine de nuestra labor como voluntarios de la Asociación Buena Vida.
Soy Raúl y estoy curado.
Soy Majo, estoy curada.
Soy González Julio y estoy curado.
Hola, soy Susana y estoy curada.
Soy José Luis y estoy curado.
Soy Graciela y estoy curada.
Soy Adrián y estoy curado.
Soy Andrés y estoy curado.
Hola, soy Miguel y estoy curado.
Hola, soy Gabriel y estoy curado.
Soy Carlos y estoy curado.
Soy Nelly y estoy curada.
Soy Claudio, estoy curado.
Soy Rubén y estoy curado.
Well, hello, and thank you for joining us today as we take this moment to raise our collective voices in the fight against stigma and discrimination faced by people living with hepatitis B. My name is James Merson, and I'm the Global Therapeutic Area Head for Infectious Diseases at Janssen. Now, I've spent my career focused on exploring new avenues of research in the fight against infectious diseases, including hepatitis B. And I've also seen firsthand the devastating consequences that stigma can have on mental health and quality of life for individuals. At Janssen, we're determined in our pursuit to reduce the burden and improve health outcomes for millions of people living with hepatitis B. And we're proud to be partners with the World Hepatitis Alliance in doing so. And together, we share a deep and urgent commitment to ending stigma and eliminating viral hepatitis. As many of you know, we partnered with the World Hepatitis Alliance on a recently released report looking into the impact of stigma and discrimination in hepatitis B. The report sheds light on the realities and challenges people living with hepatitis B and their loved ones facing each day, and reveals how systemic discrimination impacts mental health, quality of life, and overall human rights. Now, the report is a stark reminder of the health inequalities that we continue to face today, and at Janssen, we firmly believe this must change. To truly understand the feeling of exclusion, isolation, and blame that continue to threaten the livelihood of people living with hepatitis B around the world, it's important to listen to their unique lived experiences. So today, we're going to elevate some of those personal stories, and in doing so, we'll address the urgent policy and educational reform that's needed right now. To join us in the discussion, we're grateful to have several special guests whom I'd like to introduce now. First, we're pleased to be joined by Lian Tran. Lian is an epidemiologist at the WHO Collaborating Center for Viral Hepatitis and a regional executive board member for the World Hepatitis Alliance. Next, we're joined by Dr. Robert Gish. Dr. Gish is a clinical professor at the University of California and practicing hepatologist. And we're also joined by Jeff Lazarus, who is an associate professor at the University of Barcelona and current vice chairman of the board of the EASL International Liver Foundation. And finally, we're happy to have Jason Crum with us. Jason is an active volunteer and a community advocate for people living with HIV and hepatitis B. My sincere welcome to you all of our panelists, and thank you for being here today. We really appreciate you taking the time for this important discussion. Now, just a few housekeeping notes before we get started. I'd like to remind our panelists to remain muted when they're not actively participating in the discussion to avoid any possible disruptions. Also, we should have time at the end for Q&A, so please do share your questions via the live Q&A box on the screen, and we shall try to get to those at the end. So let's move into the questions then. Has Leanne been able to join us? She has. I'm very pleased to see you there, Leanne. Welcome. So to get us started, Leanne, can you tell us more about the World Hepatitis Alliance's stigma report? Specifically, what does the report highlight, and what do you think is the most important takeaway?
Thank you very much, James, and thanks everyone for waiting. I was like my other session leading just before this one just went over time a bit. That's why I joined a bit late, but happy that I didn't miss anything. So yes, I guess, so the stigma report is something that we are really proud of, that we published that. And thanks, Jensen, for the support to produce that report. So the report is the first kind of its own to have a collection of stories about the stigma and discrimination of like individual real people around the world who live with hepatitis B and facing stigma and discrimination in their lives in so many different phases of their lives. And then based on that, we built on the research and give and propose some recommendations that need to be addressed, need to be done by policy and decision makers, by community, by research community, and also for people. In terms of takes away, like your second part of the questions, I think I would be biased if I choose some takes away, if I have to choose like a few, because like I feel like I want to choose everything. So everything in the report has its all value in the takeaway, and there's nothing that can be replaced or nothing that could be talked less. But anyway, because like that's a question that I had to say. So I guess the two things that I want to mention when we talk about takeaway, if I have to choose. So one is that the experience of stigma and discrimination that people living with hepatitis B face is really diverse. It has different phases. It has different level of impact. It has some similarities in terms of like not letting people to actually work or contribute to the best of their potential. But it is really diverse, and I acknowledge that what we have in the report, or like what's the stories that we have in the report, it's just like some aspects of that. And if we can, like by whatever reason or by from whatever support that we can have, that we can collect more stories, like more lessons like that. That'll be a much stronger community voice that can, like we have heard about the role of community in policy and in everything. So if we have more, I think that is really strong support to those. And the second takeaway is that there's actually some big giant disappointment of how our society is constructed. So we are discriminated by people in whatever profession that they can be. They can be just people we meet on the street, people giving education, or even sometimes our healthcare providers. But I guess the most painful part is that we are discriminated by the government. So it is a kind of institutionalized discrimination that is written in the policy in many countries, and not only by the employers, not only by private sectors, but also from the government as well. So I think and we saw that in some stories in the report, and I think that's a painful takeaway. And I want all the policymakers or decision makers to aware that how cruel the system are, not letting people live their life.
Yeah. Leanne, thank you for sharing that with us. I'd like to build on that, your perspectives actually with Jason, if that's possible. Jason, can you talk a little bit more about the impact of stigma? And I know you do quite a bit of advocacy work. Can you tell us why decreasing stigma and discrimination around hepatitis B is so personal for you? Jason, I think you're on mute. You need to come off mute. There you
go. The stigma around me, it's very personal because as I was trying to advocate for myself to get good quality health care, the doctor that I had didn't really know how to treat Hep B, HIV coagulation together. So I had to travel 290 miles away to St. Louis just to get in a cohort study in order to qualify for treatment. Because there's a thing called medical stigma, and where doctors don't know how to treat a patient. And so I've also experienced faith-based stigma, where you experience stigma in the church setting. And so I identify with Dr. Lin, regards to stigma, how serious it is and how it affects a person's ability to want to come out and participate in functions like these. We want to come out and participate and be a vocal asset to the community. You have other countries that have cultural stigma, where have hepatitis B, you must have done something that they consider deviant to attract it. So, I mean, stigma is just a real bully when it comes to being an advocate, being a patient, infected or just not infected.
Jason, thank you for sharing that with us. I think the sentiments that both yourself and Leanne picked up on, where suffering from hepatitis B is a cruel fate, and we need to work out how we can do a better job managing this. Thank you for sharing that. Let me move on now to people living with hepatitis B and having reported facing isolation within healthcare settings. Perhaps Dr. Gish, from your perspective, how do we increase physician education so that someone living with hepatitis B can enter a healthcare system and be met with compassion instead of fear?
It's a fantastic question, James, and thanks for having me at this very important meeting and panel discussion. I think the educational process of providers has changed dramatically in the last 3 to 4 years. Our international organizations where we attend for our education historically have been scientific, and now ASLD, EASL, other organizations are bringing patients not just to the organization, but to be at every committee meeting, to be on every panel, to talk to us. I was at a meeting in Washington, D.C. last week for 3 days on hepatitis B, and 2 of the main speakers were patients, giving their perspective directly. And another one of the patients is also a scientist who talked about his perspective as being a patient with hepatitis B, but also surveys that he had done among the patient population. I also want to compliment Janssen because 4 years ago, we were in Vienna when Janssen started a stigma process. And I would say I was close to zero in terms of my education at that time, other than a few one-off events with patients educating me. But by starting a whole project on stigma, self-stigma, societal, employment, personal, family, I expanded this, 100 times. So I really think we need to continue this educational process. And the rule of 7s probably applies. Maybe providers are smarter and just a rule of 5s, but they're going to need to hear it 5 to 7 times before it changes what they're doing and what they're thinking. It was a great question. Thank you.
Well, I have a follow-up question for you, Dr. Gish. We've seen how reducing stigma has recently been included in the hepatitis C treatment guidelines. How could similar changes help addressing stigma for people living with hepatitis B?
Fantastic question. And as you know, there was an open public comment period from a CDC document about screening for hepatitis B. And in that document, for the first time, stigma was in a front and center position. Historically, we were risk-based questionnaires, right? We were asking all sorts of different questions about all sorts of behavior. And this was stigmatizing in and of itself because we weren't really trained on how to ask those questions. So now we're changing to a model of testing everybody. This destigmatizes because everybody gets tested. We can now soften our risk-based approach because we still need to ask about risk because some patients will need repeat testing. But let's take that to a much lower level. Test everybody, educate people on why we are testing, but don't put stigma as the front filter on what to do. And we're not getting to elimination unless we test everybody. So this is a major move forward. The US CDC really has to be complimented. And of course, WHO has put this in a front position, but now we can harmonize hopefully across the globe with this process.
Thank you, Robert. Yeah, it does sound like we need to have a more comprehensive support system for our patients going forward. No doubt about it. Thank you. Jeff, I'd like to move to you if I can, please, and bring you into the conversation.
Sure.
People newly diagnosed with hepatitis B are often provided with inadequate information about what their diagnosis means or how to effectively respond. What can healthcare systems do for those individuals to make sure they and their families receive the mental and importantly emotional support that they need?
Thanks for the question. I think there's a lot the health system could do. And as Bob said, the fact that patients are engaging with clinicians at conferences and meetings already helps to explain some of those issues. And as was raised in the work that the World Hepatitis Alliance published on stigma, we know these are vital issues to patients. So sometimes we just need a little reminder. So alarm systems in patient charts can be extremely helpful for for clinicians to, to remind them about the importance of emotional and mental support. For many clinicians, providing a diagnosis is as simple as saying you're positive for hepatitis B, and the good news is there's things we can do about it. For the patient, this is a life-changing message they're getting. So the reminders through alarm systems, through having culturally sensitive materials that they could provide them, a pamphlet, the Alliance and sometimes national patient advocacy organizations will have materials about hepatitis B, maybe with referrals to where they can get social and emotional support from their peers, to make sure that healthcare workers, healthcare providers, clinicians receive cultural competency training, that they're reminded, about how serious an issue this rather often simple diagnosis is for them, how serious it is for the patients. And finally, that the healthcare providers stay up to date on all the latest hepatitis B information. I realize that's pretty obvious for infectious disease doctors, hepatologists, and others, but to remember that it's very difficult for patients to interpret their hepatitis B diagnosis and what the next steps are. It's a lot more straightforward with hepatitis C, but with hepatitis B, there's a lot going on. Might require multiple tests. You might be positive and not be treatment eligible. So it's being sensitive to that and explaining it in as simple language as possible.
Fantastic, Jeff. Really helpful. So I'd like to move to Jason and Leanne now, please. The fight to eliminate stigma and discrimination requires a collaborative effort. What can we do on an individual level to break down barriers for people living with hepatitis B? Jason, let's start with you and then follow up with Leanne, please.
On an individual level, I think it requires, one is commitment. Two, it requires a team effort between community organizations and even the medical state, even medical. It requires a great effort, not just on one person, because you can't fight this fight by yourself. It requires a team effort. For example, I collaborate a lot with a lot of different organizations and pharmaceutical companies, either as a consultant and a patient, not just representing myself, but representing other patients. I also collaborate with the Hepatitis B Foundation as a storyteller, as an individual, as a patient, as a colleague. So it's different ways that I attack being an advocate and to help eradicate or deface stigma. So it all depends on the person, from their background, where they're coming from, and what they're trying to do with it, if I'm making sense.
No, absolutely, Jason. And I was actually, you're putting yourself out there, as you say, for yourself and representing other patients. Changing policy is a tough thing to do. And so there needs to be a level of persistence at the very least, but sharing the patient insights is really important. Can you just provide us perhaps with an example where you felt like you got some real traction with speaking and working with these different bodies?
It's given me a bigger platform, for one, to do my work. So without not knowing who the story center is, without not having experienced the relationship with the Hepatitis B Foundation, I've never been able to become a consultant to the scientists for GlaxoSmithKline and Gilead and other places like that. I would never been able to do this here with you guys. Mm-hmm. So it's given me that platform. Now, once I'm on the platform, it's up to me to decide what I'm going to do with it. So I have to, when I'm doing stuff like this, I have to remove myself for any personal issues. And I'm not just being a patient, I'm being an advocate, representing the patient. So what I do for the community, I'm also doing for me.
Yep.
So it's for me, it's a each one teach one effort. And hopefully, even if one person comes out from behind the walls of stigma, that's worth it. You know, it's not about me. You know, I'm just a little small piece. I like to say dynamite comes in small packages.
There you go, Jason. I love it. Thank you. Leanne, can you provide any additional perspectives on this?
I'm really with Jason in terms of acknowledging I'm just like a salt in the sea. But if we are together, like one salt here, one salt in the US, one in Australia, one in each country, that can actually make salty cup of water. And I'm so happy that to see that we have the courage to actually to come out, like you said. And then that actually took courage, and I'm actually amazed with the resilience that that my peers that I experience, that I see in my peers in terms of how people do not let the diagnosis or the stigma of living with hepatitis B define who they are or limit their ability to live to the fullest, to contribute to the society. So I think that's what people like individually, people living with hepatitis B can do. Just live your life, just contribute, just love people, just do the things. And then that's the best way to educate other people. And then, because you asked about individual, I think we do not live alone in this world. So there's actually people who do not live with hepatitis B, and what those people need, I think what important is that we need love, we need compassion. So that seems, so, you know, I used to think that all the stigma and discrimination was actually from the lack of awareness, but it was not. It's not always, it is a part of the problem. But then the key point, the key things is just the lack of love, the lack of compassion, the everything that is going on. And then people do not have that enough. So I'm happy to share like my personal like experience of disclosing my status. So I had my friends who got rejected when disclosed that to their partner. I was luckier. So when I disclosed that with my boyfriend, now my husband and father of my two beautiful daughters. So when I disclosed that to him, I was met with empathy. He understood. He did not know much about hepatitis B. He actually had some terrible misunderstanding about it, but he chose to love. He chose to go along with me instead of like stigmatized, instead of those. So yes, I think it's like people just make love and compassion and empathy. So, and just normalize it. Do not see us as a condition. See us as a person with a chronic condition, just like any other chronic condition. And look, because there are actually treatment that can suppress the condition, and there's actually vaccine to protect everyone. So just live a normal life, and people just like look at us just like anybody. We do not require that you feel pity for us. To just work with us hand in hand, and we're doing it together. Yeah.
Gosh, thank you, Leanne. And Jason clapping there. Yeah, absolutely. You guys really help us in the scientific and clinical communities. We do need to better understand your perspectives and how it influences the work that we do. I think clearly empathy, love for you guys, providing that infrastructure is critical in how we collectively can create a better environment for supporting people with HBV infection. So thank you for sharing your insights, folks. So Jeff, I'd like to come back to you, please. From a policy perspective, what is the most urgent action for policymakers to improve the lives of the millions of people who are currently impacted by hepatitis B?
Thanks. First, if I may, I just wanted to comment on what Leanne said, because it's so moving and also really hard to understand for a lot of people in the health system, or I'm working in a hospital, but as a researcher, because from our side, at least in many cultures and many contexts, there's really no stigma or discrimination. You've been diagnosed and we want to treat and help, and people need to be reminded about how much stigma and discrimination there is out in the rest of the world and in society. I think, and I hope there's people watching this seminar who aren't already, I hope we're not just preaching to the choir, because the World Health Hepatitis Summit will bring people interested in hepatitis, but we have to get this message out that there's no reason for this kind of stigma discrimination. It's completely bizarre and absurd, and it's so difficult, though, for some of us to understand it until we hear what you just said. And in terms of the question for policymakers, I guess not to just repeat what the World Hepatitis Alliance has been saying for years, but it is about finding the missing millions. I mean, it is about increasing funding for outreach programs to reach people who are difficult to reach, because that's what it is. It's not that they have trouble coming to the health system. That's true as well, but the health system has trouble thinking outside. I'm looking out the window because I'm looking at my hospital, and we have trouble getting outside of our compounds and going to the community. Here in Barcelona, my colleague Camila Pichio is leading a project where we go and we work with peer outreach workers among the migrants, and we're testing during religious ceremonies in community centers and mosques and in other settings, finding 10, 11, 12% hepatitis B prevalence. So the policymakers need to know that there's a lot of hepatitis B out there, even in very well functioning health systems like here in Spain, where there's universal health coverage, where there's free access to all the treatments you would need, whether it's B or C or HIV or anything. But we don't have the funding and the support for these kinds of outreach programs. And I think that's a major issue for policymakers all over the world. And the others, issues are really related into better access to some of the diagnostic tools we need. It's not just about having the reasonably priced point of care diagnostics. It's about who's allowed to use them, where they're allowed to be used, how we connect when we test in the community with the actual health system. We need policymakers to facilitate, all of those processes.
Thanks, Jeff. And Jeff, with the policymakers, ensuring the patients have got really the comprehensive support they need, what access do you see them having to peer and mental health support services? Because it sounds like that's a pretty important aspect of their well-being.
In some settings, and I think it will be very few, you'll see social services, social welfare ministries are linked and working collaboratively with the Ministry of Health. And in most, it's not the case. And we need more joined up approaches where social care or social welfare is not seen as something different than healthcare. So, and then also to be able to facilitate support for the non-governmental organizations. So one thing is the social ministries of social welfare working with the healthcare system, and the other is actually support for patient organizations. So in some well-resourced countries, you'll see that these are patient organizations are literally supported by the government. There'll be materials available in waiting rooms provided by clinicians in charge. But then I think in most countries, you'll see that that's not the case, and they're struggling for funding, struggling for survival. So we need, really to facilitate the role that peers can play. In some cases, you'll even see peers you can get an offer of a peer being with you, when you get a diagnosis or follow-up care. Again, that's not very common, but there's good examples of that. And that's, I think, what needs to be scaled up massively.
Thank you, Jeff. Yeah, clearly work to be done. Okay, I'd like to ask the panel, and let's start with Dr. Gish, about taking one or two final comments, if I may. If you had just one message for people living with hepatitis today, what would that be? What would you tell them, Dr. Gish?
My message to individuals living with hepatitis, and the big focus of this today is on hepatitis B, is to become involved, be educated as part of that involvement, and then be part of our messaging that we're trying to deliver to the community. And this message is hepatitis B is a treatable condition, a disease, but we can destigmatize through this educational process, decrease or stop discrimination.
Thank you very much, Dr. Gish. Leanne, it'd be good to hear from you. What key message would you like to take away from you?
I guess the key message is just like, look at us, consider us as a person, and do not consider that us as a public health threat, not consider us as an infection, and treat it just like you treat anyone else, like you work with, and that's actually, we are happy to be involved, Dr. Gish. I mean, like many of us are happy to be involved, and the only thing that we wanted to make sure that we have is that is a meaningful involvement, that it is a real engagement, but just not like some tokenism way of engaging people. Like that's what I experienced firsthand myself when I was involved in a number of like policy and research activities. So sometimes it's just like, okay, tick the box. So I'm with policymakers, I'm with clinicians, I'm with researchers, and I just want to be hand in hand with everyone, so we can go further on this journey.
Thank you for your advocacy, Leanne. That's great. Jason, thoughts from you, please?
I like to consider myself as the stigma slayer, if you will. And I say that because when I come out and whatever I'm doing in regards to this community, I'm giving empowerment. We are giving empowerment. Dr. Lim and I are giving empowerment to other patients to let them know that it's okay. Because each patient that comes out a little bit more gets chiseled away from the wall of stigma. And the more that comes out, the more that gets chiseled away, and eventually that wall is going to come down. And so that's what I have to say. That's what I have to contribute.
Beautifully captured. Thanks so much indeed, Jason. And Jeff, if we can finish this piece up before we move to the poll questions, that'd be great.
Sorry, James.
Yeah, Jeff, what key message would you like to leave us for people living with hepatitis B?
Oh, just the last key message.
Yeah.
Just to know that, you're not alone. There's so many people. I mean, I'm looking at Leanne. I don't know if people on the screen can see, but I mean, so many, and Jason, but I mean, so many people care and are so well-meaning. So to also give the benefit of the doubt, but to just keep up the good fight, because on our side, I think there's so many people within the health system, and I know all the clinicians involved are incredibly committed. So it's really about getting the policymakers to understand and to getting society to understand. And I know that changing the perspective on stigma is it's a long road ahead. So just hang in there.
It's a strong motivator for us in J&J to make a difference. That's for sure, Jeff. Actually, I'm going to actually let Bob Gish have the last word, because he just chatted to everybody about the importance of mental health as one of the final frontiers, just like cancer. Bob, do you want to just expand on that for everybody, and then we'll move to the poll?
Well, what brings this mental health issue to the forefront, of course, is what's happened in the United States over the last few weeks with all of the violence and shootings that have taken place. And this is because mental health is terribly underfunded. And I think mental health has its own stigma attached to it. And because of underfunding, underrecognition, and stigmatization, it's really not being managed like hypertension or diabetes or some of the other major illnesses. Even hepatitis B gets better treatment than mental health, I think, in the US. And globally, it's an issue. I've been to Vietnam 24 times and trying to find a psychiatrist or psychologist in Vietnam You might as well look for a beluga whale someplace that's just not available. It's not recognized as a public health need. And the final comment on mental health and talking to our colleagues, and especially talking to our patients, is something called motivational interviewing. That's something that I've just learned about over the last year, again, because AASLD is getting their act together on how to have us as being real providers. And motivational interviewing is a very important part of dealing with all of our patients on how to have them be a partner, how to get them to a positive frame on their disease, their condition, and how they're dealing with their family, themselves, their work, their environment. So motivational interviewing is my super closing comment. Let's learn it. Let's use it.
I'd like to learn more about that, Bob. Probably not right now, because I need to thank all of the panelists. So thank you, Bob, Jason, Jeff, Leanne, for sharing your insights with us today. I think your willingness to be so open and to share your personal experiences and to demand change, it's really powerful. It's motivating. So thank you for taking the time to inspire us. Now, before closing today's session with some questions from those of you listening, we wanted to get your input via the following poll question. So is the poll questions being shown, Rachel? Yeah. The question was, while all the below are vital, which of the following policy reforms are most important in eliminating stigma in hepatitis B? And the poll is to assess health systems must provide accurate, accessible information and timely services to people newly diagnosed with chronic hepatitis B? Or do the audience feel ongoing hepatitis education must be prioritized for all healthcare professionals as more important? Or viral hepatitis testing must remain confidential and should not be a requirement for employment? Or lastly, anti-discrimination laws must be established, enforced, and fit for purpose with adequate recourse given to people experiencing discrimination. So, do we have the poll on the screen?
Yes. Share the results in a second.
The results are coming up, folks. Okay, the poll is in. Thank you, everybody, for providing us with your feedback. So the most important policy reform that you folks thought was important was healthcare systems must provide accurate, accessible information and timely service to people newly diagnosed with chronic hepatitis B. I think that's pretty consistent with what we heard from our panelists today. The next most important reform would be anti-discrimination laws must be established, enforced, and fit for purpose with adequate recourse given to people experiencing discrimination. And the least popular reform was ongoing hepatitis education must be prioritized for all healthcare professionals. Interesting, given the feedback we have from Bob and Jeff. So thank you all for that. So let's move to the Q&A if we can, please. Do we have some questions, Rachel, that we can have the panelists answer? And I shall try and direct the question to the appropriate panelists. Aha. Well, actually, it's already called out to Bob Gish. Your point about universal screening reducing stigma is an important one. But how do you argue for this when the immediate counter is that in a low prevalence country, it's just simply not cost effective?
Fantastic question. I would point people to the recent publication from Dr. Toy and Sam So from the Stanford Liver Center, where it was deemed cost effective and probably cost savings to screen all adults for hepatitis B in the US. Now, we live in a expensive healthcare environment, of course, and you could say that these numbers aren't applicable to a global situation, but I would then counter that counterpoint by saying, globally, we have very, very inexpensive rapid tests that are under $5. Sometimes in volume, they're in the $1 to $2 range. And we have very effective treatments for hepatitis B in terms of suppression, not cure yet, but suppression is critical. And those are very inexpensive. Sometimes it can be just $50 a year for treatment. So I think modeling across the world is that this is cost effective. And I think we're probably going to approach cost savings like we are with hepatitis C. Hepatitis C, test and treat, saves money. It returns money to the healthcare system. And being cost effective is enough to take us across that line. We have justification. We have cost effectiveness. Homi Razavi's got great data on this as well. I point people to the WHO Polaris collaboration. I think we are ready to make this next step, and we have full support for it.
Thanks very much, Bob. Just getting the next question up. Expand that.
Yeah. I guess when James is still trying to figure out what question he is going to ask next, I just want to add something more from what Dr. just said. So actually last year in Australia, our team also did a perspective to talk about universal screening for hepatitis B in Australia. And actually we also did some research, and we know that there's actually some cost effectiveness analysis done in several countries to figure out that the universal screening will start to be a cost effectiveness at the prevalence of around like 0.4, like less than 0.4.5%. And actually for Australia, so the prevalence in Australia is around 1%. So it's surely like something that should be done. And I know for sure for many other countries with the prevalence like more than 0.5, that's also the argument as well.
Leanne, you know, and Bob, I mean, I appreciate that it's cost effective, and I appreciate, you know, that we can work out what percentage and what costs depending on the healthcare system. But you know, for me, I prefer a cost effectiveness study when we're looking at like which test to use or which healthcare system model works best. Because when we're talking about people who have this infection, I mean, how do you put a cost on that? And I work in the health system, and I realize I know how to put a cost on it. And I know that's what, you know, policymakers and decision makers and administrators want to see. But we also have to remind them that when it's deemed not cost effective to test across the society, to have universal testing, we're going to miss a lot of people, and those people are going to suffer. So I think we just have to be careful not to fall into the cost effectiveness trap that, I mean, we need that to sell. At the same time, we need these patient reasons to pay how important it is to test, even if it is a little more expensive.
I have one more addition, if it's okay, James, to this idea. And when we do cost modeling, they're not costing in stigma, they're not costing in infectivity. So even our best models aren't perfect, but if you start bringing in stigma and infectivity, this cost effectiveness becomes even much better story.
Yeah, makes complete sense.
Yeah, and then sorry, I still want to add a final thing on this universal screening as well. So actually, in a more developed health system, for example, like US or like Australia, so there's actually a majority of people living with hepatitis B actually born overseas, so like immigrants, and that so like they are actually in that intersectionality of hepatitis B. So it's not a clinical condition, but that's like so many things around that. So that's about racism, that about like gender inequality and things like that. And then actually when it is not universal screening, and then you go to the doctor, and what doctor asks you, so when and then they identify you as at increased risk of hepatitis B. So where were you born? Where are you from? So yes, so it's the story of some more developed health system that I can take example of. So that there's other aspect in the argument that we put in when we call for universal screening. We can take this offline because I can talk half a day or a day about that. And
thank you for that perspective, both Jeff and Bob as well. But we have a question from the audience which actually builds on this, and it's really very pointed. We see educated persons who are carriers who are not willing for follow-up due to discrimination. What do we do about it? So, Leanne, why don't you start with that one? That's Jeff. Jason, you're quite keen to comment. Why don't you start then, Jason, please?
I think that it's a kind of a harder question to ask because it goes back to what Dr. Pierce was saying about the mental health piece. You don't know what that person is dealing with, for one. You don't know that person's background. And so let's just say, for example, 9 times out of 10, if a person doesn't want to take care of themselves, regardless if it's hepatitis B or HIV or whatever, you have to look at the head. You have to look at the mental health piece. 9 times out of 10, they're having mental health issues. And if they're having mental health issues, they're not going to take care of themselves. It could be addiction issues. They're not going to take care of themselves, but they all follow on mental health. There's an old faith-based saying. If the head is right, then the rest of the body is okay. So if we attack the main issue up here, because 9 times out of 10, I can almost guarantee you, most of the people here in New York City who are not taking care of themselves from the HIV side, the hepatitis B side, or C side, because of addiction. And if it's addiction, because that's dealing with mental health, something happened in their past that they're not dealing with. So I think that, if you put the two together, you get a much better report.
Thanks, Jason, for sharing that. Any other thoughts on this really pointed topic from the other panelists?
Yes, I do think that it's really simple. What we have to do, we have to acknowledge that we are failing people living with hepatitis B. And if an educated person decided not to monitor their condition, which they know that can be deadly for them, so there must be something really serious. And they have made their judgment, which way to choose, whether they're happy to risk their life because against those discrimination. So yeah, we have to acknowledge that we are failing, and then we have to do things to make sure that's not happen, and then identify what needs to be done. It's the work that we need to work with people who find it personal, who decided not to go into care, even they know that it's important for their health. So, and then they will let us know what needs to be done, what actually is standing on their way to get monitoring, especially when we say that that's educated people. So there must be something big. And if they decided not to receiving care, so they may already identify what needs to be addressed. So ask them.
Thank you, Leanne.
If I may, we also need to be clear on the differences between stigma and discrimination. I mean, it's a vicious circle, but when there's discrimination, when there are laws and regulations on the books, that are discriminatory towards people living with hepatitis B, we all need to act out and make those changes. When there's stigma, we also need to understand what kind of stigma it is. Is it truly a societal stigma? Is there an element of self-stigma? And what can we do? So we need to break stigma down into smaller pieces, and we need to understand the difference between stigma and discrimination. And we know that where there is discrimination, particularly discriminatory laws and regulations, that will foment societal stigma. That will also then foment in turn self-stigma. So it's trying to understand exactly what you were saying, Leanne, but exactly what is the particular situation, and then how can we handle it? One of the beautiful things about this summit and summits we've had in the past is that there's now a global community. For the first time. Well, it's been almost 10 years now, but it's not 20 or 30 or 50 years, but a global community of people, so we can reach out to each other and work with WHO, work with others to end at least those discriminatory practices. And then we've done at the World Hepatitis Alliance and together with Janssen and others to understand the different elements of stigma.
Thank you for that, Jeff. I think we've got time for one last question. It continues along this theme, though. It's extraordinary. HPV, obviously a global disease, and yet globally we treat the disease quite differently. So the question is, do you think stigma and discrimination have different social norms when being defined in different cultures and countries? Probably best to start with Leanne and then go from there. And if we could just have a quick perspective from each of you, and then we'll wrap it up. Thank you.
I have no hesitation to say for sure. That's what it is. It is really diverse, and that's why and what impact a person living with hepatitis B or any other condition is that they are actually in the middle of so many different intersectionality in their lives, and cultural norms in from where they are from is surely one of the very big part of that one. And actually people from another culture sometimes will not be able to ever imagine that things like that can happen. So yes, we acknowledge that it is really diverse. Yeah, so yes.
Thank you, Leanne. Any other panelists like to comment on this?
I would add, to what Leanne said, when we think about someone from another culture, I think it goes back to the first question addressed to me, the health systems culture, the patient culture. It doesn't have to be you're in a different country or in a different part of the country. So I would just really remind people to, particularly those in the healthcare system, to just put themselves into the patient's shoes, to imagine, what you described, Leanne, as the intersectionality of everything that's going on. Imagine that they're getting diagnosed and they have to go home and ask, how did it go? There might be situations where they have to disclose because for medical reasons, or they're going to the pharmacy again, and so on. So it's really to consider that particular cultural context, but from the perspective of the person who was just diagnosed.
Yeah, thank you, Jeff. Bob, and then perhaps close with Jason.
I think about this every day, especially when I'm in my federal clinic in San Diego. We have 42 languages that we have on file, so I could be using 6 to 7 languages. I'm using languages to represent different cultures. Then I have gender issues within a culture also that I have to be thinking about when I'm talking to the individual. There's family members in the room. It's complex, diverse, and further part of our need for education.
Thank you, Bob. And Jason.
And as a patient, I still have empathy for the one who comes out and tests positive. And the reason for that is because a lot of times it goes back to Dr. Lazarus. I think a lot of times we believe what we hear. And what we hear is all 50% of the time is incorrect. And when it comes down to self-stigma, which is the worst form of stigma, because we've already heard it. We've already heard it from our church. We've heard it from us. We've heard it from our culture. We've heard it all over the place. And so we believe it. And it we manifest it inside of us. And so when it comes to a diagnosis, we kind of have to have empathy for that patient, because if that patient doesn't, if that patient believes what that patient hears, then 9 times out of 10 they got incorrect information, which is the biggest problem. Getting incorrect information from a doctor's office, from the medical community, getting incorrect information from the community. And so it makes my job, it makes your job, it makes Dr. Tish's job and Dr. Lynn and Dr. Jeff's job harder, because we're not only going up against a wall of stigma, we're going up against this person's individual foundation, their foundation of belief, because of what they've been told all their life.
Thank you.
So you're welcome.
No, I really appreciate it. I mean, the diverse challenges that individual patients globally are facing, it needs a collective body sharing our in-depth understanding, as you guys have articulated. So I'm afraid we need to leave it here for today. I'd just like to extend my sincere thanks to all the panelists. And quite frankly, I've been honored to be sharing this panel with you. And thank you for shedding your light, the light on the realities and challenges individuals living with hepatitis B have to face each day. And let me also extend another thank you to everyone who listened today. Really appreciate your questions, very helpful for us. And if you take one thing away from today's discussion, I hope it's that the stigma and the discrimination around hepatitis simply must end now. So discussions like today's underscore how, behind each data point, each statistic, there is a person, an experience, and a life. And we know that every moment matters. We also know that our work is far from complete. It's imperative we continue to elevate the voices of those living with hepatitis B to put an end to stigma and discrimination. It will take all of us working together to make a difference for individuals, families, and communities. At Janssen, we join the World Health Alliance in daring for a future where hepatitis B is a thing of the past. We hope that you'll continue to join us in the fight as well. We'll never stop working to reduce the burden and improve health outcomes for those living with hepatitis B. We thank you again and hope that you all have a great rest of the day. Thank you all.
Thank you very much.
Thank you very much.
Thank you all.